Okay, case number 3, who is a 70-year-old male. Before that, myself for Gilbert, and then I have Amit Huda, who is our another structural faculty who works and closely associated with me in the interventional cases also, and interventional fellowship, I would say, assistant director. So going on to past medical history of this patient was hypertension, hyperlipidemia, who also has atrial fibrillation, which may be very important in this case when we try to understand the cause of mitral regurgitation here. So AVR twice, first time 2017, subsequently had endocarditis and a redo after that in recently in 2022, and has had a leadless pacemaker after that. So we will show you the echo now to understand the mitral regurgitation and the pathophysiology of this case. Lucy Safi is on the echo.
Yeah, let's show echo live, please.
It is live.
Thank you, Dr. Kinney.
Okay.
Yes, this is Echo Live in the lab now. You can see that this patient overall has normal left ventricular systolic function. There is mitral valve leaflet prolapse with mitral annular disjunction of that posterior leaflet. The RV size and function is mildly dilated and mildly hypokinetic with minimal pericardial effusion adjacent to the RV. Looking at our mitral valve, and she was diuresed pre-procedural, but you can see that there is a predominant jet just lateral to A2P2, and it's very eccentric and laterally directed towards the left atrial appendage and left upper pulmonary vein. Looking at NPR here, you can really appreciate the eccentricity of this mitral regurgitant jet. Underlying anatomy, as I mentioned, there's a posterior leaflet prolapse with that disjunction seen from central to medially. And then with color, you can see that the regurgitation actually is just lateral to that, to P2. I'll show you that in a little bit. The mitral annulus, mitral valve area measures large, 7.6. Again, probably because of that disjunction and prolapse. Anterior and posterior leaflet lengths are appropriate at 16 and 17 millimeters in size. Again, you can see that eccentric jet. And then when we look for flow reversal, we do have flow reversal in the left upper pulmonary vein. It's blunted to reversed, and then also blunted right upper pulmonary vein and blunted right lower pulmonary vein. And actually, I did pulse the left atrial appendage, and it was reversed in the left atrial appendage. This is our septum. It is hypermobile and not quite aneurysmal. And this patient has a prosthetic aortic valve with a dilated root. The valve itself is normal in function, no stenosis, no regurg, minimal tricuspid regurgitation with no significant pulmonary hypertension. So I'll stop right there.
Okay. Gilbert, do you have to add anything into this pathophysiology? The question is, what is the cause of the mitral
I think it's,
regurgitation in this patient?
so, you can see there's some primary MR, which is, posterior leaflet probably a little bit lateral, not central to P2, but also another dilatation. You saw that's why the coaptation is also reduced, and that's why you have both components involved. So.
Okay, good. So we went through this.
Gilbert, maybe you can just talk about the heart team. You know, you have a very active group that does surgery, 70-year-old. Thoughts on how the heart team decided on one approach versus the other?
Yeah, I mean, certainly this is a surgically repairable valve, but then we have third re-op sternotomy. So I think from the overall standpoint, I don't think it's unreasonable to do TEER, as long as we get a mile or less MR, and we think we would. It's a focal jet, it's not a multiple jet. So I think we should be able to get a good result with one device here. So.
That was an interesting point raised about heart team, and when surgeons see the patient, definitely most of the valve IoT cases. I mean, we have Gilbert with us all the time. In this case, since it was a combination of both primary and maybe secondary because of atrial dilatation, and since Gilbert mentioned two sternotomy already done, this was a case was discussed with the surgeon but not seen in the clinic. But otherwise, every primary MR is seen by the surgical team here at Mount Sinai. Yes.
So it looks a very nice case for TEER. It's very broad prolapse. So if a surgeon was going to treat this, they would treat the entire disease segment. Do you think you can treat it with one clip, or maybe you need more than one?
I think we'll start with 1 and see. You know, look at Neil, you can see here on the presentation, there's a big P1, P2 indentation, right? So we don't want to disturb that. So if you start adding more, you might end up pooling and you end up having new jet. So we're trying to go very focally right near where slight lateral A2, P2, you know, maybe in a 1230, 630 kind of orientation, not exactly 6 and 12, and then we'll see how it looks once we grasp. Also want to grasp as much posterior leaflet as possible. Obviously, we want a little bit indirect annuloplasty effect to reduce that MR as well, in addition to just, you know, taking care of the primary pathology.
Which
Okay,
clip
so
are you
this is a
planning to
summary and
use?
we have already done the transeptal, right?
Sorry, there was someone has a question on the panel.
Which clip are you planning to use?
We're going to use one XTW.
There's only one
I mean,
clip
you
for
could
this.
also argue the other devices available as
Yeah.
well, commercially now Pascal as well, but we're more comfortable with MitraClip, so we feel that I think one XTW should do the job. So let's see, we'll see.
So you can see here the transeptal infraposterior, they got a height of 4.6, right, centimeters, right there. Can you show the echo also
Yeah, can you show echo, please?
for a second?
So this
Yeah.
is our
So that was
transeptal
our
location.
transeptal.
Yep, as Dr. Kinney said. And the height there was appropriate, at least 4.2 millimeter, or centimeters.
So very important to show earlier that, go back to the transeptal.
Yes,
You can see that the one before that.
yes.
So this is a very common view. This is a bicavo on the left side, explained to the reverse four chamber or short axis. And you can see here, you can already see the mitral valve where it is. You can sometimes even measure directly from there, or even you can use that view to puncture if you need to. So
Yeah. And you always use Safari
I brought the
wire
guide
and
in.
we have the
and the guys are
guide is already across.
And now this, okay?
Yep.
Okay.
So here you can see I'm going to go do a waterfall so she can put the clip in. Obviously, you want to make sure it's key appropriately. So let's find the blue line. Okay, here, make sure it's not twisted. So this is the G5 system. It's commercial, available in the United States. Nice thing about G5 is more ergonomic than some of the novel features we'll talk about later. And so what you do here, you can see once you get the this little thing clasp on the cradle, you're ready to go. You can see that on the floor. The clip just stays right there, so you don't need to guess. You can reduce actual radiation. So Dr. Kinney is now going to advance slowly. Okay, we're coming out, and while I retract the guide, the stabilizer, to steer. So you can see Lucy showing us the Coumadin Ridge. Obviously, you don't want to injure the Coumadin Ridge. And so now we're going to go into this aerial projection, and she's going to go
Very important, we have to
knob.
straddle.
Yeah, and you can see that she's now completely bypassed the Coumadin Ridge, while at the same time going posterior. And then she's going to go down to the valve. Okay, so, and you want to be perpendicular on your trajectory. So don't over-am. So some people, you try to over-am, and then that end up being, you know, too much am, and you have a medial dive. So now you can see on aerial view, I already orient the clip.
Bubbles.
And you can see that here. Maybe we can turn down the flush a
Down
little
the
bit.
flush, yeah.
Yeah. Okay, so I think we're ready to go. We want a little bit low lateral, so we can advance the stabilizer. And we go to
So
brace
this,
grippers. And can we see the system here? Good. So G5, there's no lock line or knock. So this is very easy. So just unlock, turn this, and you're in business. So it's much more ergonomic. And then now we go to open the clip. You can see that here now. We just open to this much. And then we go test the gripper, so you unlatch. So we go tactile and test. So tactile is posterior, so TP, and non-tactile is anterior. So it's very important to lower this slowly. Don't slam it down, because then you can avoid and injure the leaflet. So now Lucy's going to do our 3D MPR, and she can comment on how it looks. So we're ready to go from an orientation standpoint.
Yep. So positioning looks okay. Let me.
Any comments on that panel? In
Very,
terms of the
very
technique,
nice
this is kind of our
imaging.
standard operating procedure. So
Do you guys use MPR routinely or just 2D and 3D en face?
So we have started using MPR routinely, especially in commercial pathology. But sometimes what we've seen is that sometimes when you go into the ventricle, it's shadow. So we sometimes grasp on 2D because you get a better resolution. So let's see what Lucy says about our orientation and trajectory here on the pathology.
Looks good. What do you think?
I think we are exactly where you want it, 12:30.
Unless you want to go a little bit more lateral, I think it's okay.
Yeah, we can go a little bit more lateral. We can just
want-
so all we do is just push in a little bit. There's no, as long as the trajectory is perpendicular, you don't need to change the amp.
So I'm
So
going
this
to
is
ask
pretty good, right?
one of our panelists, Akil, and Omar, grasping on MPR or 2D?
Yeah, I mean, I like the strategy that Gilbert mentioned. I think the resolution with 2D grasping is still going to be better than 3D. The exceptions are if you have very medial or lateral jets. Once in a while, if you got great imaging, we will do this entirely in MPR, and we feel comfortable with it. But I think you have to flex back and forth a little bit.
We often start with NPR, and then when we get sometimes frustrated, we'll say we'll go to 2D, and then we're very happy.
Yeah, we do the same. So we go to the MPR, line everything up. If Jaffer thinks he can see it well enough, then we grasp on there. Otherwise, we'll move to our
We go
regular.
to 2D,
Yeah, I think
Turn down
everyone's
the
the
drips,
same.
please.
We turned down the drips already.
turn down the drifts, go to 2D.
So we are there. We looks like we went maybe a little lateral, perhaps. What do you guys think?
You have a bit of MDEL trajectory there.
Right.
Yeah, I know. So I
It's better now.
actually add a little bit M to
I'm gonna
to
counterclock.
account to that.
Yeah.
So maybe this is better.
Pulling
Yep.
back,
Yeah,
open the
See, this is
clip
the
area.
benefits of MPR.
I'm going to open a little bit more.
Go posterior, right?
Orientation still good?
Yep, Gilbert.
Posterior,
Yep.
okay, it's looking,
Okay, so both are on. I'm going to drop the grippers and see. So the key is drop slowly, okay? All right, so I'm going to lock, and I'm going to just close, go a little posterior as we go along. Posterior is long, so we don't have to, we might need to optimize, but let's see. So, and also we advance a little bit to go below the annular plane.
advanced it,
No, not too much.
good, okay.
So I like to close slowly. I don't know what everyone thinks. And now I like to go 2D now to see.
2D.
Because now you have, we've been misled before sometime MPR. So yeah, I would optimize posterior here. Look at that. I don't like the lift. So
Remember, posterior is long. It's like
yeah, so I don't, so we don't even actually,
Can we stay on 2D?
yeah, we'll stay on 2D. We don't even actually look at color because we know we want to optimize there. Okay, so now we gotta go open.
You got a lot of posterior in there already.
Going posterior,
Yep, one moment. Yep, good. Okay, so I'm gonna raise gripper.
So we routinely measure the leaflet like you all do, and we have a saying, no
Yeah,
leaflet
we do
left
that
behind.
too. Okay, so looks like we have everything, huh, Lucy?
Yep,
Yeah, you got a lot
looks good, Gilbert.
Okay, so it's a
Okay.
lot of this very much.
good.
Okay, so I'm gonna lock again, and then I'm gonna slowly close. The key is not on fluoro, not to distort the valve and change orientation. Yeah, the posterior is very long, actually.
Yeah, remember, that's the disjunctional leaflet.
Yeah, that's the
It's-
disjunctional
it's like
aspect of it. Good
16 to
point.
17 millimeters.
Okay, so let's show some color and see now.
Sorry, I lost my
Hopefully one and done. So let's see what Lucy showed us in color.
Yep.
So that's the
A little bit
indentation.
There, yep, which
Yep.
was present before, actually.
So there's nothing
that's
on the
great.
original spot. So let's do a complete insertion
Yep.
interrogation. Any thoughts on the panel so far?
well, it's like you predicted, Gilbert. You pull on the indentation, maybe it opens a bit, but when you deploy, the coaptation may be restored and that jet may improve or disappear.
Yeah, gradient should be okay.
Yep.
We'll do a
Gradient
3D
as well.
just to evaluate.
I don't see a need
And
for a
get us a
second device.
insertion.
I agree. Once in a while, you can get this jack-in-the-box phenomenon where when you have exaggerated leaflet prolapsing, they shifts the color around, because a lot of the color can get trapped under the leaflet, and it's not visualized until you put your first device in there. But this is a great result so far.
Continue, it needs time.
a little bit of,
So let Lucy do the reconstruction and then tell us what she thinks in terms of orientation and also
Insertion.
the insertion.
so we're A2P2 proper.
So we went a little bit more central, you see that?
Yeah, but it's okay, because
That might not be a bad thing with that
I didn't want to
indentation,
open up the indent, exactly,
right? To Neil's point,
yeah. I think it's good, I mean, to me, it looks like I didn't quantify it, but it looks mild or less.
what do you
at this
guys
point.
think?
Looks good.
Agreed.
Looks good. Can we
The
push
jet
in?
is not,
Can we push in a little just to
Sit-
see the anterior leaflet? Did you see it? I mean, I'm sure it went in, but there's just a shadow right now.
Yeah,
yeah, Lucy can look at that.
see if I could advance. Let me go isolated view for you, Omar.
Yeah, she can show us on isolated view. There we go.
Yeah, that's good.
Are you worried about anterior? Is that what you're saying?
No, I just doing a complete checkup, just making sure that we see it with the tissue
Yeah.
bridge. But I think we saw it.
I mean, it's not that long there,
There you
but that's more lateral now.
Yeah,
That's the anterior
That's
leaflet.
good.
Yeah,
It looks great.
Yeah.
okay. I think we'll deploy this. Anyone would disagree with that or move somewhere else?
No, it
I
looks
think
good.
that's good. Gradient is low. I could
Yeah,
check
gradient's
it again
low.
if you
I
want.
mean, I don't think we need a second one, you know, because it's an indentation,
Better
so
give the insertion.
insertion's good.
Insertion
It's
looks
good?
Yeah. So, okay, we're gonna start opening. So we always check the final arm angle on the LAO view to see the arms. And you can see the nice A2 now, very nice on 2D that is taut. So you wanna make sure the clip is not opening while you're checking the final arm angle. Sometimes there's a little bit of relaxation, but if it starts to open, then you have a problem. Then you need to troubleshoot. And then we're gonna go tight. We're gonna start the drips. Okay. So now with G5, I don't know if you can see that here. It's really nice. So drips are
Show
up.
the
drips out.
So we-
ceiling camera again.
Yep, so we open this and then unlatch, and then you're done. Just pull this. We pull it now perpendicular to the device. With tricuspid, we like to do a little more slower because of the thinner leaflets and more fragile. And then once you see the pink, you can go quick because that means the lock line's already away from the patient. So we again do one final arm angle check. You can see it's not opening. And you just go to neutral. You go back to RAO. One reason why we like to do that, we want to see when you release whether there's any rotation of the clip. So we take the parallax out. You can see that here. So Dr. Kinney will get into position. So this is unlatched now. This is very easy to do. And then you expose the groove. Expose the groove now. When you turn, it becomes just hard stop. There's no need to figure it out. And you see it. Okay, make sure this is latch. Okay, so I'm going to do 9 turns.
Yes.
8 is the minimum, 9 for good luck. 4, 5, 6, 7, 8, 9.
Yeah.
Okay, now, grip her up. Oh,
Oh.
okay.
Oh,
That was a little bit of jump, but that's okay.
It's a redo.
Very stable though on release.
yeah. So let us check
So
the
Lucy now can show us the,
MR again.
Sure.
Yeah.
See what the MR looks like.
okay, so we can take that out.
Careful, careful.
So we just need to aspirate when Amit take it out, so,
Is that just the indentation?
go ahead. Can you help?
Yeah, there is
And
now.
this is the jack in the box that I referred to, right? When you release, that blood is trapped under that prolapsing leaflet. So I think we're starting to see that here now.
Yeah.
Can we see the 3D? Because we said before, you might need more than one device because of all that prolapse.
Plus, it'd
Yeah.
be nice to see the orientation of that clip.
Yeah.
I looked a little bit.
We need one more.
Yeah, let's see.
I'll show you 3D.
They tried
It's a little bit of guide shadow.
No, but the prolapse,
What's the map before? The map.
There's no way.
We need one more.
See what that 3D looks like.
All right,
Shows
let's see how it looks to see whether we need another one.
getting guide shadow, so let me see if I can work around your guide a little.
Remember, there's a dielet annulus, there's a secondary component as well, right? So I think the question is whether we did, most of, and it's a long posterior leaflet, so you're not going to be like a classic surgical repair where you bring the entire posterior leaflet down.
Maybe if you withdraw your guide or torque it anterior, you can see the posterior leaflet a bit better.
Yeah, so I think
Here.
that, because we went a little bit more central, there's a little residual there.
Steve, what would you do?
You want to,
Well, I'm trying to see.
you want to
the
put an XT
orientation
next
of
to it, or
I think we need a one more.
do we have enough length to do it? Oh, that's actually more medial.
Yeah, just medial to the clip where you still
Yeah,
have PG
open
prolapse.
XT.
area.
No, is it a medial or a lateral? Go back to the
Medial.
3D.
It looks like medial.
It's medial.
It's the medial's the
This is
worst
the
of the
primary
two.
jet.
It's medial, right?
Yeah, medial.
I mean, the lateral one may be in
Yeah.
the indent,
The
but
indent,
the medial one looks like it's on the
That's right.
prolapse.
Sure.
So if you can measure the width medial to that clip in
Yeah.
the commissural view, we can decide XT or XTW.
No, we like XT. So interesting question, right, Neil? So we got burned before by 2 XTW because you can pinwheel, you can distort more because the why. So we now, even for tricuspid, do this alternating wide, narrow combination. So we've done, for example, like XTW middle and then go XT on either side. But we don't do 2 wide clips next to each other anymore. So
It's definitely easier to put an XT beside an XTW, I agree.
But you wouldn't use a W
Yeah.
in this case, would you?
because we've seen jet between the clips and then obviously you can't do anything about it. That's the problem.
Especially this one right next to it, otherwise you'll go from the jack in the box to the whack-a-mole technique.
Yeah, this is coming medial.
Yep.
Okay, everyone votes for XT, Gilbert.
Okay, so medial to that. Okay, we can do that.
Flush.
This one, this one.
All right, then.
You can do whatever you want.
Okay.
This one.
What was the gradient? I'm sure it's plenty large.
Gradient's 1.
1, okay.
Gradient's 1. I think
The valve
valve area
area
baseline
start
was 7 point
was
something.
around 7, so
Yeah,
it's
the LA pressure was kind of low to start with. Did it change at all?
Not really. But you're right. Absolutely, it was pretty slow to start with. So we didn't have. I mean, also you see the atrium was big and the jet wasn't wall hugging or anything like that. So
mean is 1.
Yeah, they did.
And pulmonary venous flow?
we can look again.
I'll
Lucy,
look
you want
at
to
the
show
other
us
veins. I looked in the left
did the
upper.
venous flow improve?
Just show us the worst vein that you had.
The left upper was the worst.
Yeah.
Yeah,
I
these
got
are
that.
still a little bit blunted.
We usually prep 2. We just today we thought 1 and done. So that's why we had a little delay. So.
Okay.
It's still pretty fast, Gilbert, from start of prep
Yeah,
to
this
now.
is,
Gilbert, there's no rush in these procedures.
Yes.
This is not a TAVI.
well, this is Sinai speed, that's.
There you go. He's honest.
Yeah.
Otherwise, David Adams would not allow us to do this. Okay, we're gonna come out now, the guide, and you can see the clip,
The question at the beginning.
okay? So we can again do the same thing, put it in there, and then it's come out as we retract the stabilizer. Good. So now we have to go medial to this, right? So it's very important to go. Go. So make sure you don't hit the first one.
Wait.
Yeah, go.
Oh.
Yep.
No, that's it.
Good.
Oh,
So yeah. So the most important thing is, yeah.
okay.
Perfect. Good. Okay. So we might need to restraddle it just a hair.
Yes.
Okay, we're pretty good. We probably need to aim a little bit more. You see that we're not at 90 degrees on the echo, even though the flow looks pretty good. And then we just go back into where we're supposed to be. So this is kind of where we are. We like to do what we call kissing clip, if we can. So grippers up, unlock again, and then we go to open again. Okay, almost above the valve, so we have to be very, very cautious of that. So this is our TA, tactile anterior. Okay. So now we're
Close
gonna,
it.
You want
see
3D?
now, see how it's shifted already? So let me close the clip now. So you should, orientation should be pretty much the similar.
You want 3D or no?
Okay, so one moment. So let me just,
So the second clip is kind of fluoro guided, right?
yeah, a little bit.
far away.
So hold on one second.
too
You
much.
can see that here.
Orientation, change.
All the end.
So make sure when you go in, the orientation hasn't changed.
The panel thinks you have a bit too much M on.
Yeah, we undid the
But
M
you can
already.
address that underneath, that's fine.
Yeah.
Yeah.
Yep.
But
So
interesting,
now
you
we're
did
under.
Need to do a 3D to make sure your arms, you're just using fluoro alone, is that right?
All right, we're coming up. So you can see,
Gilbert, you want X-plane or you want 3D at all?
explain is fine.
Okay.
You want to do a 3D check?
We usually don't. We can.
Well, Lucy's
If
going
it's
to get
on
bored.
already.
I like the 3D
Okay,
check.
we can
better.
do 3D
I'm
check
happy
if
to
you want.
keep going,
Here.
Gilbert, if you want,
We're exactly where it's supposed to be.
whatever you want.
Okay,
And
go.
we'll drop the
Release.
grippers here.
Yeah.
Changes with orientation will.
You want to go posterior a little bit more?
No,
Seems like you could pull up a little more.
okay. Want to do 3D? Go
You want
ahead.
3D?
Yeah.
Sure. Your orientation is 6 and 12.
We're right there.
Yep.
Any comments?
Looks good.
That looks good.
It did seem like your
Okay,
first
close.
one was a little bit more clocked, but
Yeah,
Well, I
correct.
think
We were,
the aorta is offset, it's not really at 12 o'clock if you compare it to the mitral orientation.
yeah. Yeah, we need to, we usually put on 10 and 2, so, but I think we can close.
Yeah.
Any concern about the, we're closing now slowly.
Yeah, close.
A little bit more posterior. Just good. Give back a little bit. All right, we're close, so let's see. So you can see there's a little bit higher.
Mm,
You can see it.
You want color?
yeah.
Yeah, so let's see.
Iron. The one
Much better.
That's promising.
it's good.
And the indent color went
No
away
color.
too. You got a 2-for-1, Gilbert.
And there's definitely less prolapsing of that posterior leaflet. I think that's the key here,
Yeah.
because
And you can see on fluoro how close we are, huh?
Can we show an
You can see
X-plane?
actually, you can see it distorted the first one a little bit.
Let me just real fast check.
We like to kiss, but you know, we'll see how it release. Sometimes you just can't do it because it's pulling in so much.
Mean gradient is unchanged. One.
You happy with the insertion panel?
1 second.
Yeah.
And Lucy?
That looks good.
Looks good.
Second clip is always tricky. Sometimes you think you have it, but you may not have enough because you're so close. And with this
We
prolapse,
see
you want
a
to make
3D
sure.
as well?
Any concerns, Lucy, from your end? Do we need to optimize posterior?
I wouldn't.
3D?
What'd you say?
It looks good.
Because we've been
With a little
burned
bit of
before.
Can you
Spontaneous
show us
contrast
the
in the
indent
left.
color on 3D? It looks like it was gone on the 2D.
Sure. Sure. 3D.
Doesn't speak up.
That's better.
Posterior. And the map hasn't changed. It's around still 90, like so systolic 130s.
Oh, sorry.
Test.
So let's show some color and see.
Yeah, looks good.
Looks pretty good to us.
Yeah.
Beautiful.
You guys happy?
It looks great, Gilbert.
All right,
Great work.
all right. So we'll deploy,
Release
okay?
that.
Okay. All right, so same thing, same motion again.
Huh? Ready?
So we're gonna go
Okay.
check our final arm angle. Slowly, making sure it's not opening. Then we tighten it. Okay, now the same thing drips up. You unlatch, and then you, this time it's the other way. Make sure tap on floor, just make sure everything's accounted for. And then you can see once pink, it's easy to go. Okay, so now again, check for another final arm and go again. Not opening. Okay, so now it's loose. Okay. Okay. All right, so now we have the pin unlatched. Okay. Here, expose the groove. Remember, this time it's the other way. So now with hot stop is good. So now we're ready to go. So 1, 2, 3, 4, 5, 6, 7, 8, 9. Here, press up. So we're going to go slowly to redeploy. Good. Little bit canted, but I think it's still acceptable.
It seems like
Yeah.
there's
I think when you're
residual in between.
Yeah, when you're so close to the other one, I think sometimes that's what happens. We usually don't see that kind of canted. Because there's a lot of tissue pulled in already, so. Yeah.
Still a great result, guys.
Yes.
Yeah, nothing you can do about here. No.
Okay, if you are done with this case, we'll be moving on to the fourth case,
Yeah.
to the next room.
Okay.
Agree, Gilbert?
Yeah. Okay, we'll do a
Panel.
final assessment, pulmonary vein flow, gradient, all that stuff. So. All right. Flush, please.
2.
Yep. Okay.
I'll quantify this MR,
Yeah, it's a high velocity jet, right? I think because it's between the two.
mainly between the two.
Yeah. But if you look at the orientation, they actually just cockeyed a little bit.
Okay, the veins are better.
So,
The right upper vein.
but the orientation is pretty preserved, actually. So.
Yeah.
Okay, so we're gonna go back to the right atrium now. Always do it on the fluoro because you have leads, you don't want to drag anything along with it, so. Folio protamine, please. All right, thank you, guys.
Guys,
Great
I
job.
think we have an aortic case next door waiting for you. Protamine's in? Thank you. And you can see the final ASD assessment. No effusion. Good. Ready?
That was great, Gilbert. Excellent case. Are we ready for the next one? So, Neil, but before they get on to the next case presentation, so anything that you would have done differently on either the first or the second clip, because those are, you can see the orientation of the clip at the end isn't exactly the same as when you're
Yeah,
deploying
yeah.
the clip. You know, you try to get the majority of the MR on the very first clip, hoping to be one and done, and sometimes you're wrong and you can't predict it. Is there anything that you would have done differently on positioning, orientation, choosing the clip on this case to get it to be one and done?
So for me, this was at least a 2-device case from the beginning when I saw the broad prolapse. I know there's anodilatation, but this is P2 prolapse. And if Gorai was operating, he's not just going to do a single alpha area. He's going to like try and take care of the whole segment, put in a ring. We don't have rings, but I would have just started medial XTW, probably put another one beside it. The result was still excellent. It was mild, but putting a clip medial to first clip is harder. And the trajectory was a little bit L to M, and so that's why it's a little bit tilted. But luckily, the human body's forgiving. I think Omar had a point.
Yeah, I think, I think lining up your orientation to the aorta is a bit of the old way. I think you have to line up to your medial and lateral commissure and go perpendicular to that, right? Because your aorta can be, it's not always at 12. Frequently, it's at 11:30, 12:30, 1, wherever.
We're still 12 and, we're still 12 o'clock when our aorta, and when it's not there, I know the surgeons aren't always there, but when it isn't there, I get a little off. Are you still at 12 o'clock on all the orientation? No.
No. We go based on the commissural, not based on the.
Okay.
Yeah, same. And I guess, I I would add the other thing is it seemed like maybe they could have pulled up a little bit more on the second device. In the end, looks like there's certainly a lot of tension because when it was released, it looked quite a bit different. But I do think that little dive, as well as maybe not being as high, it could have made it a little bit more stable, or at least the orientation they thought they might get.
You know, the other point, and maybe Akil, Omar, like 3D has revolutionized the procedure, makes it fast, predictable. So if you have 3D, even though it's second clip, you could do it floor guided. I think making sure your orientation is perfect, particularly with an XT, which can kind of get stuck in the chords, why not use it?
Yeah, I mean, I agree. I think, we use it as part of our workflow routinely, mostly because of the unpredictability that you might see. I mean, you saw in the first case that the device did cant a little bit, the first clip that was placed. So the nice thing is you can go in and out of 3D and 2D within the push of a button.
1 or 2 clips.
Two.
You saw that case very quickly done with the 2 clips, and now we are ready for another one. Is everybody ready?
We're ready.
Ready, go for it.
Beautiful. So this is the case number 4 now. And
AR1.
this patient presented with the lightheadedness and dyspnea on exertion.
Right,
The
right
bypass
sinus.
surgery.
And the right sinus.
And the various things which are shown here. Patient has a surgical valve replacement with 23 millimeter
Take your
Magna
T up.
T valve.
Right sinus.
And the medical therapy, you can see, good medical therapy. Patient has a low ejection fraction.
AR1 is coming.
And the rest of things are okay, with the creatinine being, the BMI is 40, very high BMI. BMI is 40. And but what we found in this patient, it was done actually, it's a lived his life in terms of having 2008 and now to 17 years, and now have developed degeneration predominantly, and the little bit of mild transvalvular AR, and moderate MR. And EF was about 40% and has an angiogram done recently with all the grafts open. So with that note, actually we are going to show you the active echo also, but let me just present a continuation. This was the echo before with the high gradient and degenerated valve, and maybe when STEM has a time can show what on the TE echo.
I will do after the cross. Is okay?
Oh, they want to cross first, but you have to show the valve or no?
No,
He has recorded images.
Okay,
Stamp
okay.
show the recorded
Okay,
image.
I was trying to help you.
No, they want to.
Yes, so
These
again, mid-esophageal view.
hard.
Ejection fraction about 40%. With the posterolateral hypokinesis, right ventricle is normal. This is a bicommissural view. It has a few chordae ruptured with moderate lateral regurgitation. This is the left lateral appendage is clean. The mitral cuspid regurgitation, minimal pulmonary regurgitation. This is the aortic valve. As you can see, the leaflets are thickened, decrease motion. Also, the patient has aortopathy. His proximal aorta is like 4.2. This explain again shows the leaflets, decrease excursion and thickening of the leaflets. No much AI in minimal aortic regurgitation, as you will see in the deep gastric images.
Even, no.
Again,
no,
the LV
no,
function, no pericardial effusion. This is a deep gastric
3D
images.
RT.
As you can see, minimal AI, no paravalvular regurgitation as you expect on this bioprosthetic valve. The maximum velocity we got today is about 3 meters per second. Mean gradient of 22, max gradient of 36. Aortic valve area of 0.5, 0.6 centimeters square. Pro volume index about 20 ml per meter square. So it's a classical low flow, low gradient aortic stenosis of this bioprosthetic valve. And this is again a short axis image of the aortic valve showing the degenerated leaflets and wide open left main. Thank you very much.
Okay, so clearly it's a more degeneration versus the regurgitation, and the ejection fraction was on the lower side. We can continue our presentation of the case with the slides.
You have 3D RC
Get me a 3DRC.
or a no torque?
Yeah. Okay. Yeah, no, let me just see, go back.
Bring your T up.
Yeah.
T up.
T probe up stamp.
Yeah.
You can see this is 23 magnet.
Yeah.
You can see that there in the
Use a guide. It'll give you more.
Not the guide, man. You just be in the center.
your secondary,
We can't hear you very well, Gilbert. Can you turn up
Okay.
Gilbert's
You know,
microphone?
1 second, okay? Fix the Gilbert's microphone, please. Now, while Gilbert, and we'll show you the active crossing the valve. Many times these surgical valves are difficult to cross. Various techniques, whether it's AR1, AL, or various wires, including V18. Sometimes we use, sometimes guide catheter helps a little bit pointing out. And that's where we are at present, while we are presenting this, the rest of the presentation.
Lima guide.
I think this will be reasonable. No, I think if we can break a little bit and show what's happening with the fluoro, so that these are the tough issues, and I'm sure people will love to learn that what is your strategy to crossing this tough surgical valve.
Let's go live on
Go to fluoro
fluoro.
for the time being, please. Go to fluoro.
So what all did you try, catheter wise?
Go back to the live fluoro.
So normally LAO view, but for surgical valve, we like to go to RAO view or, go to a view where you can see a end on. So this is a different catheter. I don't think this is helping us at all.
Yeah, so we, AK has tried AR2, and this is IM or JR catheter,
3DRC.
3DRC. I think sometimes the guides really help in these cases gives you the support to really point in the middle of the valve. What does the panel think?
It looks like
Go with
somewhat
the
horizontal,
multipurpose guide.
Yoda. How about AL1?
Right. Yeah, AL1 we can use. Yeah, that's a good idea. But would you use a guide or a diagnostic?
Diagnostics should be good enough.
Okay.
Okay.
Let's get the diagnostic.
AL1 diagnostic.
Do you know, so it sounds like the gradient now is 21. What was the gradient maybe earlier on? Because it seems like the leaflets do move a little bit. I wonder if there's an element of PPM in this patient's pathophysiology.
Great question. Stam, what do you think?
I mean, I don't have the echo after the procedure, but I will say that the last echoes, there are 3 echoes that we have, and the velocities, it's about the velocity from the transthoracic that we got yesterday is about 3.5.
About 3.5, 3.6, and then remember this is about 17 years now.
Yes.
The 2008 was the valve, but I'm sure some part of the PPM maybe because of the 23 millimeter.
Yeah, and also
Yeah.
big aorta too,
And
big
the
patient.
aorta definitely is dilated also.
Yeah, and big patient. So I think it's combination, most likely of degeneration and some PPM. But the gradients definitely have increased since.
Look at the aorta.
Yeah. Yeah, I mean, I think
It's always a
surgically,
challenge.
Have a AL2 running
L1,
also?
L1.
we
No,
would
no,
expect
L1
a
going.
23 in a large patient probably would, we would leave the OR probably with something in the low teens already, so.
Yeah.
It went from the
Yeah, I mean, but
13 to
surprisingly
21 in
patient did
18
so
years.
well
That's
until
pretty good.
now. You're right, this, knowing the area will be too small.
Get a
Exactly what
AL2
it is.
next.
How
So much
often are you
better the
using
AL catheters.
TEE for this? Is that routinely used?
And remember,
used TEE?
under anesthesia, they always go down by T, at least by 15, 20 millimeter. We saw it many times. I'm sure you have experienced that also. Now, right now, we are the AL1 diagnostic. With a large aorta, it's the right thing to do because based on the size. This one is the one I will start to begin with the AL1.
Yeah.
And so many times we have this, our stiff Terumo wire, 038 straight tip, and difficult cases we have worked with the V18. Sometimes V18, we have not tried V18 yet, right?
No.
Yeah, no, I think that's a good point. So SS, if it's a very stenotic valve and a pinhole opening,
almost there.
V18 makes sense. But when you have huge
Still under the
sinuses
right
and a
hand.
small valve, you need directionality more than the size of the wire. So I think the directionality is provided by these catheters, and I think AL1 is a great choice.
Yeah, there.
Yeah,
There,
AL2 would be my second option here. Very good. Yeah, keep trying. You're in the center. So you can see on echo how centered, she is, and
Give the V18 one.
yeah, go try in that area.
There.
They were asking a question, how often we do TE in these cases?
Yeah, almost all valve-in valves, we are still doing TEs. I don't know how the practice has evolved in other centers, but we are using TEs for all valve and valve.
Yeah, you do, I mean, it's in the right sinus.
Is there a reason why you're using TE and general anesthesia so often? Why not just do surface echo and conscious sedation?
Particularly if
I
you're
think
not
that's a
doing
very
leaflet.
good question. A lot of these valve-in-valve procedures, a lot of these valve-in-valve procedures end up requiring some kind of a fracture or end up requiring leaflet modification. So I think this has sort of been a practice. And also we want to make sure that, we have excellent gradients and there's no paravalvular leak or transvalvular leak in these cases.
Right there?
It's just been a practice. Remember, valve-in-valve is maybe 5 to 10% of your volume. So it's not that much. It just sounds a lot, but not really that much cases doing TE.
So we didn't see the CT.
Is that where it is?
Can we show the CT images, please?
We didn't hear about the VTCs and that, so.
Sure, sure.
Just 1 second. We'll show that.
Let's
Yeah.
show the CT scan in the meantime.
Can we show the slide presentation, please, while they crossing? Can people hear me now?
No, but let's, you have it.
Can people hear me?
Go direct.
Yeah, we hear you, Gilbert.
Yeah.
Can anyone hear me?
Yeah, we can hear you.
They can hear you now. Yeah.
Okay, good. All right, so you can see the huge root as you saw on the aortogram. You can see sinuses, and you can see also next slide that the top of the surgical valve is right at the STJ, but STJ is massive. So you can see that there would be no coin obstruction risk, and that's why we go to fracture this and put a supra-annular valve there as well. So you can see this here
Remove your
again.
TE up, oh, okay, okay.
Remove the T up.
Access was okay, a little bit
Yeah,
tortuous,
it's
but
pretty tortuous access, actually. It's, was a tricky access here, guys. Very tortuous, multiple bends. So type C, transfemoral.
this is the valve-in-valve app. For those who are not familiar, I encourage you to
nice.
download that at your own
And
leisure.
record
You
this
can see that the
completely.
true ID is 21,
Hey,
so we're
fluoroscope.
going to fracture with a 23 true, even though they says 24. If you do 24, you might have to upsize it to a 29.
No, it just
so
prolapsed, nothing to
I
do
think
with it.
23 is still
That's not
probably
the
the
thing.
safest choice, because
That's
sometimes you cannot
Such a
fracture
difficult
that much.
case.
And you can see that here.
What's the point?
the,
Difficult case, instead of
target
showing how we are
expression.
crossing, we are talking the.
Okay, so this is the summary. So let's go back to the case.
Okay, let's go to the case with the valve fracture in the plan. Now, tell us, so you know what we saw? The very difficult, and this is where expertness, usually we always bad. Anytime it takes more than 2 seconds, 2 minutes, for even a complex valve, we get all the staff extra lunch. We do lunch quite a bit. This kind of when you have the valve degeneration is in trouble, and this case, we use a V18 wire. Maybe Anu can show it.
Let me
Yeah,
tell you, okay, let's show, if you can go back to fluoroscopy, right?
Yeah, you're on Toro.
Okay, there. So like Sahil mentioned, I think it's a catheter that you needed to orient at the right spot, but what V18 does it just prolapsed. You see that? You see it prolapsing inside.
Very nice.
Yeah.
So SS loves V18,
I can tell you that there is only one randomized trial of the aortic valve crossing, which 3 centers we did. There was a guy used to be Louis Cannon in Maryland, and there was one more, 3 center, 91, 92. And we came up with various strategy. And this is a V18 is a very good wire in a difficult case, particularly
Spot.
in a surgical valve degeneration.
Give a pigtail. Get us a
It's
pigtail.
not. Okay.
But
Tell
I
us
think
now
more
what you're doing.
importantly, Dr. Sharma, is the small surgical valve, right? So this is actually not that small, but the root is big. So that's the issue here. So if you have a 19 surgical valve and a big root, that's a big problem. That's very tough. Because the true ID is only 17, plus degeneration and stenosis.
One day, Dr. Sharma will tell us to use a rota wire. It's just a matter of time.
Now let's ask our audience, the panelists, will anybody do a tower? In this case, if you cannot fracture the valve.
Do we know the valve area, the perimeter of the valve area?
0.5 to 0.6, as Stan mentioned earlier.
But was that planimetered or calculated? Calculated will be
That's
low because
planimetered.
it's low flow.
It's not
Yeah,
used.
yeah, planimeter is 0.8.
0.8. Planimeter
Could be,
0.8.
say, probably it's wrongly placed. Ay, ay, ay.
We are
No, no,
interfering
hold
with the anterior mitral valve.
Yeah, yeah,
Now it's better now.
no, still.
I think it's just
You were
the,
caught in the aortal, the subvalvular apparatus. You can see on TEE on the long axis. So that's why we like doing TEE. You can see that, you know, I know everyone likes to be minimalist, but you know, these are difficult cases.
good, much better, yeah. So that's at the base,
Okay, now,
and we can just use a Safari now to straighten it out. Just leave it there.
So I think
we
we
can
also
get the
should
stuff
take
on
the opinion and the vote by our panelists. That have you started doing the tower with just minimal support, means no anesthesia, just conscious sedation and very few people in the room, minimalistic tower.
Go slow, go very slow, slower.
So for valve and valve, the only time we're
Now
using
push,
GA
push, push.
is if we're gonna
Push,
do
push,
a
beautiful.
leaflet
Yeah.
modification with TE guidance,
Yes.
but otherwise conscious sedation. Even with valve fracture,
Okay.
conscious sedation.
Okay.
All right, TEE up, please, Stan. We're gonna fracture the valve
Yeah.
You
now.
come that side.
Yep. You good?
And
Yes,
another
thank you,
point,
sir.
valve fracture before or after?
Before. Oh, yeah, let's discuss that.
That's it.
After,
Oral Peter Bikini.
Before.
after.
So I think in
Let's
this
take a
case,
vote.
this
TEE
case, I
up,
think,
please.
Yeah, more, yeah.
Yeah.
in this case, I think
Thank
you're
you.
really
Tell him to
beneficial by
show
doing it
base,
before, because
not
it looks like
this
there's
ceiling.
one leaflet fusion, and I think no matter what valve you put in as the valve, you're gonna have trouble with full expansion, so I'd rather do this first.
No, we need to
And
view
I know
fracture.
Gilbert discussed 23 or 24, I'd probably use a 24 true to do this.
Yeah, it's a very good point. 2 ID plus 3. Yeah, let's see how the 23 behaves. But very good point.
Yeah.
So are you guys
And everyone is
fracturing
gonna pre-fracture, correct?
pre-fracture?
Even Neil.
Valve is ready,
As
check.
long as you have your valve ready and you go
Good.
fast, it'll all be good.
So this first?
I mean, there's some data to support, do it post.
Yeah.
Yeah, I mean, it does have lower gradient based on the papers, but, you know, they do have higher mortality, this with balloon expandable valve.
That's the only.
So base
Okay,
180,
180.
please.
Okay.
And show Dr. Keeney's hand there on the side.
Pull back.
No.
Okay, now go. Lock it, good.
Didn't they?
And Sine.
Okay,
Yep, it
broke.
Okay,
broke.
broke.
Back up, back up.
And back up now.
100.
Excellent. Good, let's take it
So we
out.
pace at 100 to unload the LV for QAR. So when we quickly walk this out, we like to map out to make sure that your balloon doesn't, sometimes the balloon can rupture, that could be a problem. That's why we don't do inline here. We like to have an external sheath.
Pull, pull, pull.
Yep.
Keep going, keep going, keep going. Okay, get me the evolute, please.
No, no.
While you're putting it, want to show what exactly happened there?
No, 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 let's just finish first.
So here,
Don't do aortogram.
you can see the waist is gone on the left side of the screen.
So I think Hassan mentioned
Yeah.
about 24, right? Or someone mentioned.
Yes.
Yeah, 23 is a reasonable size here. 24, sometimes I've seen can become a little more aggressive. So I don't think it's an exact science, honestly.
Correct.
If you can get enough pressure, enough contact, you should be able to get good results.
Yep,
And some fractures, even with 24, you struggle, right?
yep.
Keep going.
So,
We'd love to see the TE if the patient's stable, to see what effect you had.
Yeah,
Okay.
yeah, we'll be happy.
Show the
Before
T
you
now.
go.
back here. Push the Y.
Wait.
Push the Y.
One view, let me find the good sun.
And give me a little jiggle.
It's not a jiggle, it's in the wrong outer.
And this
corner.
is
So then how does it look?
This is common when
then
the
let's do
aorta is so
Nagars.
big and you're trying to
Some,
get this valve delivered, that it's a little struggle.
There's no
So when we come here, just
No much AI that I can see.
No.
Yeah,
The leaflets don't open
Yeah,
more.
it's
than
good,
There you
yeah.
go.
So little
Close it,
juggle
back,
always
close it.
helps.
Yeah.
If
Okay.
you saw a little
So
juggle
obviously
towards
people
the
can
end.
use stare and other techniques as well. But
Yeah,
let's
moderate-
begin now.
Moderate AI and the leaflets open definitely more than when we started.
Yep.
Bro, remove the parallax.
Yeah, I am trying.
Yeah. Good.
Most likely we can now capture the jet, the centric jet
That's
Prep
not
the
bad,
blue
actually.
balloon again.
of at least moderate AI. Yeah.
Okay, 150.
Go.
Very nice.
Oh,
No.
Popped up.
I said it's very low.
no.
Go down,
Okay, good.
down,
And stay
go
there.
down.
Stay there.
Okay,
Stay there.
go deeper.
No, deeper.
Yeah.
Okay, good. Push the wire. a little
Push
bit.
the wire and start here.
Okay, good. 180.
Give it some time.
Good. No. Okay,
Okay,
100.
100.
Actually, 120.
That's nice.
Okay. Pick-
Do a
push,
cine. I
push,
want to
push,
see
push,
what's.
push it.
Yeah. Do a cine.
Push.
Good.
I would go in.
Okay, one moment.
To me, it looks okay.
Yeah,
Yeah, it looks cine here.
You know, the
I like
depth,
it. Yeah.
the depth
What do you think,
depends
guys?
if you think you're gonna post dilate this. If you think that there's a chance you're gonna post dilate, because there's some space on the left side, you may wanna implant this a little deeper.
But they did fracture the valve,
I
so-
think even we can post dilate with this.
Yeah.
Okay.
No, two dots are below, one is.
Center the wire.
yeah, the valve tends to go a little deeper with this platform. At least.
And Gilbert, you know from implanting these surgical valves, that what we see as the bottom of the ring is not
Base
really the bottom of the
180.
valve, correct?
That's right, yeah, we could the in here.
Do it under cine. I can't see anything. Okay, thank you. Yeah, perfect.
Now
that,
you're
guys.
better, yeah. That looks
Yeah, I
good.
know. Very nice.
Yep.
Push the
120,
wire. Push the
120.
wire. Okay. And
Actually, a little low.
yeah.
We need to
and
push.
Back up.
Good.
Back up
Go to
now.
back up. And get me the balloon, please.
24.
Thank you. Go
Well,
ahead.
this is a 26, right? So IFU is only 23. This
Give
is a
me the
26
23.
envelope, no?
Uh-huh.
So, yeah.
23.
Take it out.
Help me here.
Okay.
How does it look, stamp?
No,
Go ahead.
no PVL.
1 second. 1 second. This is- yeah.
I think I'll go with I know this we always have. Both the Gilbert and Sahil, they always have 1 millimeter smaller balloon size than what I usually say. But
Well,
that
we're
at
good
least
to-
good thing is there's no rupture. No
Yeah,
annular rupture.
that, well, not that there's balloon rupture, Dr. Sharma, because of the high pressure. We've seen that.
That's fine.
so- No.
Test the pacer once more, please. Yeah, just pace 110.
But Gilbert, you're choosing the post-dilatation balloon based upon the constrained portion of
IFU.
the, correct?
Yes.
And that would be
So the
23 on this valve.
P up,
Yeah.
IFU, no, I want to see the depth. You have to ascend.
Depth is great. Yeah, depth is great.
Okay.
Okay, good.
Go deep on
Oh,
the
yeah,
balloon.
yeah.
Go deeper.
Yeah,
Okay,
we're
let's
good, we're good, we're good.
go. Okay, 180.
Cine on the inflation, please.
Very nice. Good.
Good.
Keep pacing, keep pacing. Keep pacing, keep pacing. Keep pacing, 150.
Careful. Wait.
Yeah. And
Okay, back up, up.
That was an
Okay, got a
excellent,
pigtail.
Okay, good.
that was an excellent result. You moved that valve even further out to the surgical valve.
yeah. Yes. And I think you appreciate the depth, right? It can be misleading sometimes, but
So the dot marker is helpful, so to be fair, the left side of the screen is around 1, okay? So the other side is around 2 and 3. So if you really want the superannual benefit, and I think so, this is about as high as you can go. The problem is that we recapture once already, you can't become rubbery and you kind of perfect the enemy are good. I don't disagree. I think for the less experienced implanters, going a little bit deeper to what popped out is very reasonable. You don't want to be 6 millimeter deep, then you kind of lose the advantage of the superannual benefit of the Evolut platform. But you can see here that, you know, if you experience and you coordinate your deployment with your operator partners, then this kind of result is certainly feasible. And the other reason for that is that if you do plan to fracture post, you cannot implant at this step.
Yes.
No way, because then the valve will come out when the fracture happens and you end up foreshortening more. So if you do that, you commit to a deeper implant, and then if you try to post-fracture and it does not fracture, then you lose all the hemodynamic benefit and the reason to do that. So that's why we like to pre-fracture, and we haven't lost a patient hemodynamically because of that.
And do you want to talk about your commissure alignment of the Evolut valve versus the surgical valve, what you were thinking about with implantation?
Yeah,
So-
great point, Steve. We have to show you in fluoroscopy what it looks like in terms of the surgical post. So we can go on maybe a
200
custom
scale.
view.
200 scale.
200.
Done.
So that's a perfect hemodynamic result. Can we show the hemodynamics, please?
That's showing it, yeah. Good. No gradient.
By echo 7 and 3.
It's actually 3 also there.
Looks beautiful.
The MR also got better.
Yeah.
Yes.
Excellent.
It's beautiful, guys.
I told these people, right? 100.
Yeah, a little challenging, huh, with the capacious sinuses and
All right, so here is so we do the Passover. You can see the commercial tab on the right side of the screen lines up with the surgical post on the right side.
It's
So that
perfect.
means we have excellent commercial alignment. In fact, you can see the two windows very nicely overlaying each other. So this is in essence excellent commercial alignment to near perfect.
Yep. Great.
and
And
we have a break now.
No.
Mr. Hill, Mr. Hill, do you want,
But let's talk about a few things.
yeah,
One, who will give both aspirin and clopidogrel to this patient, or anybody will
And
give?
anticoagulation.
Yeah, anticoagulation.
Tell them full screen,
Excuse me.
full screen.
What is the opinion?
Well, the trial suggests single antiplatelet is all you need. It reduces bleeding.
and then, you know, one technical question I wanted to ask you, Sahil, is when you were trying to get the valve, the Evolut valve inside the surgical valve, if you were
camera.
still stuck, what other tricks would you use to get that valve inside there?
Oh, yeah, that's a great question. So if you see, my nose cone was very close to the top of the stent frame. If you keep pushing there, it's just gonna keep engaging and bend into the stent frame. So what I did was I gently pulled it up, rotated the system, and Dr. Kinney was jiggling the wire. When she pulled the wire slightly, I got space and I pushed it in.
Is there a wire that makes a difference? Have you had to ever resort to unveiling part of the valve to get across? What other things can you do?
So, yeah, so.
I think it's a combination of both.
Yeah,
Wire and advancing the valve at the same time. So if you see the valve was at the outer curve, so we had to pull it back, reorient a little bit, and then it's both the wire, you pull the wire back, at the same time advance the tower.
Should we do an aortogram or no?
Yeah, do it.
we have used snares in the abdominal aorta. The Lundequist wire doesn't help, it biases more on the greater curve. So snare can be used, otherwise just jiggle.
Haven't we changed the wire, double wire?
We've tried balloons, we've tried double wires. We've struggled a lot sometimes.
Okay, we are going to show the aortogram and then we'll be done and exactly at 12:10 for your lectures. What a perfect timing. Wow.
Perfect
Gilbert
timing.
and
Perfect
AK
timing.
and Sai doing a great job. Not even a 1 minute late or early.
You have time
Let's
for another
finish.
case.
Symposium.
Can I take the pro?
We actually have a case, minimalistic case in our coronary room.
Not yet. Okay, just do it.
Okay, ready?
Yeah.
Yeah.
Yeah,
Go.
just the hair, but they did, this is good.
We may be behind.
Beautiful result.
Wow.
Yes.
Not even a single RBC. All right.